have you had experiences where patients' wishes are not granted by default decision makers?
Yes.
Absolutely.
Many times.
Do any stand out in your mind?
Yeah, I mean, pretty recently we had a patient who was essentially almost completely unresponsive to the outside world, and the family, everybody in the family, there were like 5 different family members, independently stated that the patient never wanted to be on a breathing machine or have a feeding tube. And we very clearly said, multiple people, myself included, directly said to them, they'll never be able to live, or their life, the only way that their life will proceed for any amount of time is with a tracheostomy, a breathing tube, and a feeding tube. And they went ahead and did that because they weren't ready for the patient to die, and that's literally, they said, we're not ready for him to die. But the patient had very clearly stated he never wanted that to happen. They said, up until the point that we did these procedures, that he wouldn't want this.
Sure.
And that was pretty terrible.
Right? Yeah. Yeah, and we run into that situation more frequently than people would think, really. Yeah, situations where family members will readily tell us that what they're asking us to do on the behalf of the patient goes directly against what that patient had expressed they wanted in the first place, which is really confusing. And it really, as the providers that are trained to advocate for patients' wishes, and what a normal person just out of this situation would think is ethical and moral, aside from our patient advocacy training, it's almost disturbing to see these kinds of things happen, because I think there's a loss that patients' family members don't really understand. There's an inequity of healthcare provided when you initiate long-term care intervention. So I don't think most of these patients' family members understand that when your family member moves out of the ICU, or even let's say it's a telemetry floor where they have one nurse caring for 2 patients or 4 patients respectively, into a long-term care situation, they're going to have a ratio of more like 1 nurse to 15 or 20 people. I don't think they really realize some of the health complications that arise with forced air ventilation through a tracheostomy. So that would be a machine pushing air into your lungs through a surgical hole and tube we place that Mike was talking about. And some of those complications can be chronic pneumonias, right?
Yes.
Can you think of any other complications that would arise from immobility or tube feedings?
Well, you can certainly have bed sores from immobility.
Sure.
Which can turn into massive infections and sepsis. And from tube feedings, we can also still have aspiration into your lungs of feedings, aside from the fact that you have a tracheostomy. It is possible. Yeah, I think those would be our biggest problems.
Yeah, those are pretty chronic problems that we actually see repeat visits, to the hospital for.
Yeah, you can't have a tracheostomy and not have pneumonia. It happens countless times.
Yeah. So I don't think a lot of people understand that by initiating these types of really severe interventions in their family member's life, that they're going to have recurrent hospital visits, they're going to have recurrent infections, and it without adequate neurological function or rehabilitative, an ability to rehabilitate the person physically, there's really very little chance of this ever benefiting them in terms of what people would consider a quality of life.
Yeah, if you're going to go spend the rest of your life with no hope of improvement, but we're keeping you alive through a tracheostomy and a feeding tube, it's pretty terrible. You're going to spend a lot of your life. Probably you're spending your entire life in a hospital-like environment, but then you'll be having to leave there just to come back to a real hospital, to come into the ICU because you have a severe sepsis. And you have to go through the whole process over and over and over again.
Sure.
You go through the hospital stay, you get sent back to wherever you live, you come back to the hospital, you get sent back. And at some point in time, eventually you can't do it anymore.
Yeah. And this is all about, how quality of life is defined by, the patient themselves as interpreted by family members. So this is not us saying that if you consider, being alive by any means necessary, if you hold that belief personally true to yourself, if that's what somebody says, I want to live no matter what. I don't care how much functionality I lose. I don't care if I cannot express myself to the world. I want to live. We respect that 100%.
We respect it. We may not necessarily agree with it personally, but it's not our choice.
Yeah, and we don't, and we won't, try to encourage, types of behaviors that would exclude us doing everything to maintain that belief set for you. What disturbs us is when we see patient family members that are supposed to be advocating for that person directly tell us that they're going against that patient's wishes.
Yeah, that's just about the worst thing ever.
Yeah, these decisions are in terms of, how a person will live out the rest of their days. And the prognoses that physicians are giving family members to try to give them idea of what kind of life or lifestyle this person could look forward to, what kind of functionality they could gain from it. So do you observe a lack of understanding in patients and their default decision makers in regards to their health?
Yes. There's a massive misconception. People think that, I think largely because of TV,
Sure.
They think that we can fix anything.
Yeah.
And we can't. We may be able to keep you technically alive, but that's definitely not, we can keep you alive and back to doing exactly what you're doing. Many people get hurt through various mechanisms, and we can keep their body supported, but that's really all that we can do.
Yeah, and a big place where we see this, especially in neurological medical services, so services where we provide treatment for the brain specifically, is when you have like an ischemic brain injury or an anoxic brain injury where something happens to your brain where there's either trauma or there's other insult like a lack of blood flow, like the denial of oxygen over a long period of time, which would be like drowning.
Yes.
Those things can cause what's called tissue ischemia in the brain or tissue death. And once that tissue dies, it's irreversible.
Very right.
Yeah, so we cannot bring that brain tissue back to life no matter what. And I could see how, to a lay person without medical training or experience in the medical world, they would see something like a skin graft or a wound vac and say, wow, that person was missing, or reconstructive surgery even, where we can, take a bone from another part of your body, put it in, say, part of your ankle, and that person could potentially walk again with maybe not with full functionality, but they could potentially go from somebody that had no ability to walk to somebody that could walk, or somebody that had burns over 50 to 90% of their body, and we graft them over and over and transfuse them over and over, and that person lives. That is a completely different concept to the abilities we have to alter brain tissue.
Yeah, your brain has no capability of regeneration. Once those cells are dead, they're dead forever. We can't create new brain tissue.
Yeah. And so that's why there's imperatives in situations like strokes where we say we need to get you to the hospital immediately and we need to intervene immediately in order to resolve the obstruction, resolve the bleeding, decrease pressure, do whatever we have to do to resume normal blood flow or oxygenation of those brain tissues, because there's a very minute window of time where those brain tissues will die. And if we can restore the oxygenation or blood flow or decrease the pressure that's causing the insult to your brain, then you have a much better chance of that tissue not dying in the first place.
Yes.
So that's the main cause of what we do. Can you talk about the time frames of intervention a little bit?
Yeah.
When in terms of stroke, at least?
I can. So we follow very rigid protocols to keep our stroke accreditation, and it's all centered around getting people to intervention faster so they lose less brain. So, there's a whole time frame of things. We're supposed to have you into the CT scan within 5 minutes. It's supposed to be resulted within 20 minutes. But the whole gambit is really just if you're having an ischemic stroke, we have a 3, soon to be increased to 4, but we have a 3-hour window to give you the clot busting drug called TPA. And we want you to have it in what we call the golden hour, which is self-explanatory. We want you to have it in the first hour.
Sure.
Because the studies that started in the 80s when this drug came around show that if we have these interventions in the first hour, you have a much higher chance of recovery. You lose something to the effect of an inch of brain cells every 3 minutes while you're having a stroke around the stroked area. So the damage is incredible.
Yeah.
So the faster we can get you to the hospital and get those drugs on board if you're having an ischemic stroke, the less of your brain dies and the more that can potentially recover.
Absolutely.
If blood flow is restored.
Absolutely.
If blood flow is restored.
Absolutely. Yeah, so there's interventions like the TPA that just dissolves a clot that we can give systemically, or a neurointerventionist can even insert a catheter into the vessel of the brain if it's large enough and instill small amounts of that into the brain, right?
Yes.
And then we will practice things like blood pressure reduction or very narrow windows of managing blood pressure, especially if we think that in collusion with this hemorrhagic stroke you're having like vasospasm, right? Mm-hmm. And so vasospasm, where a vessel is spontaneously opening and closing, because it's a smooth muscle still, like that endothelial part of your vessel still contracts and expands.
Yes.
So if it's doing that spontaneously, it could be spontaneously opening and closing and letting blood in and not letting blood into tissues in the brain. So we found that in really tight blood pressure parameters, we can control that more efficiently. It's almost like a miracle when I see it too, because I've literally seen somebody's blood pressure go over 160 and their whole right side go flaccid. And as soon as I turned on the drug to bring it down and they're in range again, boom, their right side moves again. No more facial droop. Instantly resolved. It's amazing.